So I will talk about clinical aspects of brain imaging, but focus on MRI, and I'll try to show you what is really within the routine clinical practice, what we do in research, and what really is the frontier in clinical using MRI. So why do we need brain imaging? And there are a lot of clinical objectives for the use of MRI, or for the use of imaging at all. We want to have diagnosis. We want to know if somebody has a headache or somebody has neurological deficits, to diagnose the reason for this. And now we can image and really, and I'll show you with a very high spatial and temporal resolution, really understand what's going on in various disorders. We want to know the prognosis. If we have 2 patients with brain tumors, we want to be able to say what the prognosis. Sometimes it looks similar. They have the same clinical manifestation, but they have really different prognosis. So using imaging, we really want to know and to be able to predict the prognosis. With the shift to personalized medicine, we don't want to have that everybody has a headache, we'll take a Camol or Optalgin. We want to know the reason. We want to know other profile, genetic profile, characterization of the tissue, and really being able to provide and to give the right treatment that will help the same person or the same patient. So really imaging is going along with the trends towards personalized medicine. And of course, if we do give any treatment, we want to be able to assess its response, whether the patient is responding. If yes, we'll continue with the treatment. If it doesn't, then we need to change the therapy. So what can we get information from imaging? We can get, of course, structural information, and different modalities and different methods have different spatial resolution to detect the structural information. But we can also get functional information. And functional mean we can see the nerve, we can detect functional brain areas, or we can detect, and I'll show you also talking about functional, the function of the vascular system. So there's a lot of function within the brain that we can detect and monitor. We wanted to know about metabolic information because many disorders involve metabolic abnormalities. So if we can, with imaging, also learn about metabolic, so it will help us again. And of course, to have a very specific tissue characterization, to know that if 2 voxels within an image looks different, what can we say about the microstructural properties of the tissue? We want to monitor plasticity. If we have stroke, following stroke, rehabilitation, children with cerebral palsy, we want to be able to see that if we do any rehabilitation, we will be able to monitor plasticity. Of course, we want also to take it one step further, not only for diagnosis, but to help even for therapy. What we call is neurofeedback, that we will be able to see how the brain functions and give a feedback to the person so he'll learn how to behave and improve his function within the brain, finally improve his behavior. So if there is a stress, if there are pain, patients with chronic pain, maybe we'll teach them how to be able to help themselves and to do feedback to what their brain is functioning in order to be able to become on this chronic pain. And many use of a lot of imaging modality is in guided biopsy, because if we do want to take a sample from a tissue, we want to know where we're taking it. And a lot of the devices now that are coming are always with the guided. So we know ultrasound is guided, a lot of biopsy, MRI is guided, a lot of combination of device. We talk about now PET MRI. We heard just a couple of weeks ago, heard about now that they do also radiation guided with MRI. So there are a lot of improvement and research in development, new devices, hybrid devices of imaging and therapeutic devices. So I'll present you some data from our center, from Ichilov, and currently we have 4 MRI systems. 3 of them are more for clinical use and 1 more for research. And all examples that coming from our center, I will show you from this and from our center and from this new system. So there are not only MRI. We have a lot of imaging methods to map the brain. We have X-ray, we have CT, we have PET, SPECT, MEG. The main difference, and in general, all these methods is just interaction between energy and material. So we do transmit any energy or record an energy, transmit for the tissue, and then we learn. We can get any method to build an image, or if it's just a signal, like an EEG and MEG, we do some advanced algorithm of inverse recording to understand where the signal comes, and finally to build an image. But in this lecture, I will focus only on MRI. And there are several advances on MRI for MRI, which are beyond other methods, and I want to emphasize. First, if we are talking about resolution. So first, when we get an image, we are interested in having good spatial resolution. Like if you buy an iPhone, everybody will say, I have 4 megapixel, 12 megapixel. We do want to have a high spatial resolution because this is our ability to detect small signals. So the MRI, here it's called it's written by fMRI, but MRI in general is not one of the best imaging for spatial resolution. We have other modalities which are even better, if we're talking about optical imaging and signal recording. But from imaging perspective, it is one of the image with a very good spatial resolution. Regarding temporal resolution, there are other methods that have better temporal resolution, and we do want to have a very high temporal resolution because this is the only way that we can really monitor dynamic changes. A lot of reaction within the brain happening within milliseconds. So theoretically, we do want to come to this resolution, and these are the two main advances in motivation in developing new technology in MRI. First, having high spatial resolution, and B, just really improving the dynamic resolution, the temporal resolution. For spatial resolution, one of the main motivation, a lot of new pulse sequences, a lot of new methods, and the shift towards high magnetic field. We have now 70, which is approved for human, for clinical studies, and they are developing 14 Tesla and 70. So we're really pushing for those two directions, high spatial resolution and high temporal resolution. Another advance of MRI is that it's used, we transmit the energy in radio frequency, meaning it's non-ionized radiation. So that's why we can have longitudinal scan on patient. There is no harm, there is no hazard for the patients. We can have a lot of volunteers, healthy subjects, scan them longitudinal, scan them for many hours. And this is something that is important. We don't want to do to use any modality because PET has many advantages, but nobody will volunteer for a study in longitudinal if he's healthy for PET, which is ionized radiation. And the last and very important, and this will be the focus of this talk, is that MRI is multiparametric. When you are talking about CT or when we are talking about ultrasound, we are talking about one contrast. CT is the density of electrons. So we transmit an energy, we see the dispersion, we get an image, we can make it isn't just an X-ray film or can compute and get an image. We can play with the window for Lang window and see it's nice, but it's one contrast, meaning there is one physical properties within the tissue that we indirectly detect. In MRI, there can be more than 20, and all the time things involve properties of the tissue that we can detect. And from each methods, we can also extract few parameters. And the main idea is to get those parameters and indirectly represent really microstructural properties of the tissue. And there can be about 40 and even more parameters that describe the tissue. And it's meaning that if I have to compare between two chairs, they can be look the same but with different size. They can be the same size but different color. They can be the same size, different color, same color, but just different texture. So as long as we have more information, we can improve diagnosis, we can improve prognosis, and we can improve all these things that I said that in clinical setup we are interested. So in general, there are many methods in MRI, and I won't be able in this 1.5 hour talk to talk about all of them, but there is a lot of structural information that I will present more in details, and also some structural and connectivity, or what we call diffusion-based methods, and vascular. Those three methods I will focus in this lecture, but I want now to give just a very short brief on those methods. So functional MRI is a method that we can really map and get information about brain areas that are function. So this is we can do it also with images, so we can do it also with PET. There are other methods, but this is indirect, non-ionized radiation, and we can really map and get. And the shift now is from talking to areas of activation areas that are responsible for specific tasks that are working, or a nerve that are working within a specific, towards a network. So meaning if I'm moving now my hand, many years ago we just look at the area that is working while I'm moving my hand. But now we're talking about networks that related, because if I'll be any disruption or cut or any damage to this network, I won't be able to move my hand. So this is just a shift from localized activation to network analysis, and I will talk about it also, and I'll come back later again just to mention this again when we talk about structural connectivity. MRS is another method, and this is actually the only method in all imaging modality that can direct metabolic information. So if we don't want to get in metabolic information, currently it's only biopsy. It's all those blood tests or biopsy that we take. We do extraction. We do all this biochemistry analysis to the tissue. And then we can know what are the chemicals within this area. MRI or MRS is one method within the MRI that can really give us information about major metabolites. And this is very important for metabolic disorders. A lot of research on psychiatric disorders that we know that involve abnormality in different chemicals within the brain, and also a push towards better resolution, better spatial resolution and sensitivity to metabolites that are in a low concentration. And there is just one field that I will mention because this is really the frontier, and very, very few studies in what we call MR elastography, which is coming mainly from liver studies. And this is just vibration and another contrast, meaning we have a lot of contrast with MRI, and all the time things are evolved. In MR elastography, we just give vibration, motor vibration to the brain, and we see how the wave progress, and we get another information about stiffness of the tissue. And this is something really just work in progress by a very few labs in the world. So I said that the most important thing is not just to image the brain. We do want to get information and to learn indirectly about microstructure of the tissue. And this is vice versa, because when we have a patient and we know what is the question and what is the differential diagnosis for this patient, according to this, we can tailor the protocol. So we need to know any information, what's going on, what we suspect, what is different. If there's differences in the metabolite, so if there are differences in metabolites, so maybe we'll choose MRS. If there are differences in connectivity or abnormality in connectivity, we'll choose functional or structural. So really, protocol and MRI protocol is tailored to the subject. So if we are talking about just injection gadolinium, anybody who has done regular MRI, many often we inject contrast agent. The contrast agent is just, when we're talking about the brain, doesn't go out from the blood-brain barrier, and when it does, when we do see area like this, enhancement, white matter area, here we know there is impairment or there is a breakdown or partial breakdown of the blood-brain barrier. It can be necrosis, it can be tumors, it can be inflammation, a lot of things that can be represented, but this one parameter. When we are talking about diffusion, and I will emphasize about it later, we have many parameters. In general, we relate them as parameters that monitor cell size. We can indirect assess myelination of axons. So in demyelination disorders, we'll run these methods. We can talk about axonal injury in disease like ALS, amyotrophic lateral sclerosis. We do expect to have axonal injury. We'll make use of this method. And of course, fiber organization, a lot of studies on brain development, both at young age and aging. We'll talk about this method, which is towards quantitative MRI, another trend now in all the research of clinical neuroscience. And this is to have values that are meaningful, not weighted. I will talk about later. and all the methods that relate to the blood system, to the vascular system. And there is a lot of parameter if we are talking about volume, flow, and I will give you example and explain it. So what is the principle of MRI? And this course is not intended to teach you what the basic, just the main idea of what we do in MRI. So when we just sit here in the room, we have all those spins, and we are talking about clinical MRI, we just monitor and image water. We monitor the proton, a proton that sits in the hydrogen atom connected to the water. That's why if I broke my elbow or any bone, nobody will send me to MRI because this is a dry tissue. So when we sit here, we have some spins and we have some physical properties. When we put a subject within a magnetic field, then we get an energy. Now we have a place that the tissue is ready to absorb energy, because I said all imaging modality are just interaction between energy. And this idea won a Nobel Prize, because for understanding that if you make any external condition and then there is a place to absorb energy and get an image, is a really, for now it looks very trivial, but was really innovative and won a Nobel Prize. And luckily what we do, we radiate RF, radio frequency, as I said, no radiation image. We get change in the energy, and like any system that absorbs energy, after we stop transmit the energy, we'll relax to equilibrium. And what we do in MRI is we absorb back. We detect back this energy, build an image, use what we call gradients to localize the image, and this is the main idea of MRI. So we do look on conventional imaging on physical properties of the hydrogen. So when we talk about T1 and T2 and T2 star, I won't go exactly what we do, but there are different properties of the physical energy level of the hydrogen connected to the water of the molecule that we detect and translate to image. So in conventional imaging, there are, let's say, 4 basic contrasts that we can detect. What we call is T1 contrast, T2 contrast, and T2 star. These two are really what I explained before, are physical properties. These are physical energy that absorb a place of any tissue, different energy level that can absorb energy, transmit energy to relax, and they are just different characteristics of the tissue. So when we talk about images that are T1 weighted image, they are related to this contrast. If we have area with a short T1, we'll get it bright in the image. On T2 contrast will be the opposite. If it's long T2, then it will be high signal. And it's not just Adobe Photoshop that you invert the image. These are really different physical properties of the tissue. Proton density is similar to what we call in CT and electron density. That's why this contrast will be very similar to what we get in CT. And T2 star is another contrast that relate also to paramagnetic effect, and this is very strong. When we have it, very strong, affected by the blood. That's why this method is used to see any bleeding or the basic contrast for fMRI when we talk about oxy and deoxyhemoglobin. So this is an example of a patient with a brain tumor, of glioblastoma, which is one of the most malignant brain tumors. And as you can see in T1, we can see it as a hypointense signal, meaning this is a long T1. Long T1 meaning there is a tissue destruction. There is a tissue destruction, we get prolonged relaxation time. So we can see structurally the location of the tumor. On T2, we can get further information with sometimes different border of the tissue. And when we talk about T2 star, you can see that those areas are with bleeding, microbleeds within the tumor. So this altogether information. On a routine clinical protocol, that's what we do. It's never one sequence. We have a lot of sequences, different orientation, whether it's like this, transverse, whether it's coronal or sagittal. And this is just the way that is more convenient to the radiologist to see anatomy and to see pathology and to see symmetry, because in axial and coronal we have symmetry of right and left, and sagittal we don't have. So this, in general, what the radiologist does really scan a lot of sequences, and now they sit and look at all the images and doing in their brain, okay, it's hyperintensity 1, it's hyperintensity 2, it does enhance on contrast, and then they give the diagnosis. So it's looking on many parameters and then try to figure out, like a puzzle, what is the diagnosis of this patient. And there is another method to help them. So we have this T1 weighted image, and this is 2 weighted image. If somebody can see any pathology or any abnormality. Okay, and now you can see. Okay, now we can see this hyperintense, which is exactly, and this are exactly the same sequences, exactly the same, same contrast. The reason that why you see it here, if you now look back, you can see this is just our brain. We always compare contrast. You'll probably learn in psychology that if I give you white pictures and gray picture, and then gray picture and black picture, we always do comparison. So if we have this bright signal of the CSF, the cerebral spinal fluid, we won't be able to see hyperintense adjacent to those areas. But when we saturate them, it's very visible. So we do develop a lot of methods in MRI really to assist radiologists for easy detection. Theoretically or basically, these 2 images are exactly the same. But radiologists and also you can see this pathology, but you cannot see. So all the development is really new contrast and to assist radiologists in diagnosis.
Question?
Yes.
How much these days the radiologists still use their vision to say whether there is a problem or take it to some kind of quantitative methods?
This is really the frontier in imaging, is to help to have tools that help them. I know in breast imaging, they have something that a software that you send, you get it back, and it helps the radiologist. It will never substitute them, but it really help. And generally, this is the trend of a lot of research, but implementation is very difficult. Just moving them from film to computer wasn't easy. But I'll talk about the gap between what we can do and what is actually done. But theoretically, we can do, and there's a lot of articles of prediction where the tumor will grow, changes. If it's basically longitudinal, you have 2 images, mark them, do registration, comparison, mark the radiologist, okay, this area was changing, even just nothing really implemented in routine beside what I saw on breast imaging. What, to trust it? It's just...
No, that it's not there yet, since it's...
yes. So what you use the clinical use of this conventional imaging. So structural abnormalities are fine. These are really good images that provide high resolution, and we can get to 1 millimeter square, or even 0.5 millimeter, or even 0.25 millimeter, depending. Increasing spatial resolution, meaning more scanning time. We can detect lesion or tumor and identify and diagnose therapy and therapy response assessment. And I will show you some examples of the use of those methods. Use and limitation. So when we talk about brain development, we just take this one T1 contrast, which is very simple contrast, nothing spatial. But during brain development, and especially during the first 2 years of life, we have a lot of process, a lot of myelination, synapse, most of very dramatic changes within the brain. And the water content of a newborn is very high relative to a 2 years old child. So if you can see, newborn with the T1 weighted image contrast is really invert relative to 2 years. So during these 2 years of life, contrast really changed from white matter here is, okay, this is a T2, but when we take white matter is black, and here white matter is white. Around 6 months, we get iso-intense. We cannot differentiate between gray and white matter in babies about 6 months. So potentially, looking at those changes, we can learn if there is a problem in development. The other problem is that first, the changes. So the variability in normal development is huge. There are babies that are walking at 6 months, and there are babies that are walking at 1.5 years, and both can be normal. And the same variability we see here. But this is something that if we'll see abnormal maturation around age 2, then we know there is a problem. What is the limitation of this method? That the contrast or the brain of a 2-year-old child and a 22 years and a 40 years old are the same by the contrast. So we do know that there is a lot of processes and maturation of the brain and more myelin and more synapse, but the contrast doesn't change, meaning a lot of children come around age 4 and 5 and they are sent for MRI, developmental disorders. So we look at the brain, looks fine. But if there is any abnormality and after 2 years it doesn't really develop, we won't be able to see if the method is not sensitive on normal brain. So every study or everything that we do in pathology, we really need to understand what is normal. And actually, imaging of development, and especially during the first year, is one of the most complicated because the normal dynamic changes is very wide. So this is something that we can see. And there is a lot of things that can be studies if we're talking about segmentation, if we're talking about cortical maturation, cortical folding also in preterm. We can talk about segmentation and get information about the white matter or gray matter specific structure. We can get normal graph of maturation for boys and girls, and we do know what is expected when we are talking about brain development. There is a specific pattern of how the cortex mature, how connections are established or again mature. So this knowledge exists, and if we have knowledge of normal development, then we can say, okay, those child has macrocephaly or big or small brain, and then we can learn about various developmental disorders. We can go further and really have, and there is a lot of free available, or for other companies that for money, but segmentation tools that we can get this adult brain and segment into different structures. The problem is that most of those tools do not work on small babies because we do assume large, and also they are not working when we have pathology. When I had a study on children with cerebral palsy and half of the brain is a big lesion, none of those tools will work for me because it assumes normalization template and there are specific tools. That's why the development of tools for other population, for small babies, atlases for small babies, or tools that do not use normal brain are all the time developed. So this is just a few examples. So this is a regular tool of brain segmentation that we can get information about hippocampus. So we can learn about aging and see in Alzheimer what the size of hippocampus relative to mild cognitive impairment or relative to normal aging group. We can have now and take patients with lesion. And in this case, it's optic pathway glioma. There's a patient with neurofibromatosis, a genetic disorders that they have a lesion on the optic pathway, benign lesion, but because of the location, many of them have a sight problem. And then we can monitor this lesion and segment it to cystic or solid enhanced or different compartment of the lesion. And we can develop a tool, and this is also a patient with also neurofibromatosis, but with different lesion. That's what we call plexiform neurofibromatosis. If you know this movie of Elephant Man, that they have a lot of lesion on the peripheral nerve, and it can, as you can see here, can be all over total body tumor. So we need to quantify this. And for your question also, currently, no quantification of lesion is done in routine. And this is something which is astonishing gap, an unbelievable gap, because we can easily quantify a lot of the lesion volume, but none of them really in routine clinical practice implemented, only on few cases, mainly due to manpower, money, nobody wants to pay for this. But it's always the question, if we cannot monitor exactly the volume, who will test efficacy of a drug? And so it's always diagnosis and drug development that must go together. Another thing is that where the world's going both in clinical research and in research and in clinical practice is towards what we call quantitative MRI. So we don't want to have images of T1 weighted. I said 2-year-old child and a 20-year-old student will have the same contrast. It's T1 weighted, it's not the value. We know that the brain mature, we know that values are changing, so we do want to have this ability to quantify them. And these are all these are images of what we call relaxometry method that we can detect R1, which is 1 inverse the T1, or proton density, and really have a measure which then I can compare. He has a value of 760 milliseconds in this area, and this will be absolute value that can be comparable across subject and in longitudinal scans. And a lot of effort is now being performed in all company of MRI vendors is to have 1/6 sequence, what they call the MR fingerprint, that in one sequence we can get this information, not anymore T1 weighted, which is related to T1. It's like having two children, one is tall, one is high. I'll tell you the difference are 20 centimeters between them, but you don't know where absolute they are sitting. So then I can be able to say he is 160 and he is 180. So this will be more valuable information. So this is another way that frontier and going, and I believe in the next few years, if this method will succeed and become without any problem, they will be implemented in routine clinical and even substitute the other contrast. So if we're going now to other methods, and I will focus now on diffusion weighted methods. And it's diffusion weighted methods or diffusion based methods because it's not one method. We'll talk about what is conventional diffusion and also about diffusion tensor and various advanced diffusion methods. And this is also something that evolve all the time, capability, and there is a difference between what's going on research and clinical practice, because if somebody develop a beautiful method but it takes me 40 minutes to acquire it, I can, and anyway MRI is long, because if we have about 6, 7, 8 contrasts and each one of them take about 2 to 3 minutes, already the patient has an exam of about 30 to 40 minutes. So if somebody develop beautiful method which will take 40 minutes, I want to add it routinely. So it's always the gap between what we develop and then when we want to translate it to clinical, it either has to be magnificent and really valuable methods or it should be shortened. So what is diffusion? When we are talking about diffusion MRI, it's a different properties. We're talking about a random motion because of kinetic energy of molecule. If you drop a drop of ink to the water, even without stirring this glass, after a while, it will, if it was a red ink, the glass, all the water will become red, just by random motion. But when we are talking about cellular tissue, the diffusion is influenced by the cellular compartment. So if it's a glass, it's free. It can go everywhere. But when we are talking about tissue, we have very generalized model. We have cells, and we have intracells, water molecules that move within the cell, and extracellular compartment. And of course, there is exchange, but during this experimental of MRI, we can neglect this change. So we are talking about water molecules which are within the cells, and they are restricted. They cannot go out. And we are talking about free water molecules that are free to move within the extracellular space. So if a molecule is diffusing fast, it has fast diffusion or free diffusion, the signal will decay. We'll get black area in the image. If it's slow diffusion or restricted diffusion, slow can be because there is a lot of protein within the tissue, because the cells was damaged and all protein, large molecule are inside and viscosity is changing, therefore there is a slow diffusion, or because cells enlarge, like you probably saw in stroke, so the extracellular, which is the free compartment, become restricted, then we'll have this hyperintense signal. And indeed, the first, and I'll go briefly because you heard it in stroke, the first beautiful example of the use and the advantage of diffusion was on stroke, because immediately, few minutes, seconds after stroke, when we cannot see anything in T1 and T2 because there is no change in the physical properties of the tissue. We cannot see anything in CT, but we can see differences in diffusion, meaning we see hypersignal, there is a restriction because cell swells, extracellular becomes small, so we have restricted diffusion and we can see stroke. And this is just an example that 2 hours after stroke, we can hardly see anything on FLAIR, which is very sensitive, but see very easily the lesion in diffusion. Only after 10 hours and 36 hours, there is a secondary effect on the relaxation time, and then we can see them. And then there is all methods of, probably heard, how to identify penumbra, also with diffusion, perfusion mismatch. You heard about it? Talked about penumbra?
It was mentioned in the lecture last week.
Okay, so this was really the first application and the first use of diffusion that was really demonstrate the huge potential of these methods. But there are other examples, and here you can see 2 examples of brain lesions, T2 and after gadolinium, and basically they look the same, right? We don't know which is which or what lesion, but when we look at that diffusion, see that this lesion is hyperintense, meaning it's restricted, and this is just an abscess. Okay, inflammation, just a process within. And this is, it's free diffusion, meaning it's necrotic area, meaning this is a brain metastasis lesion with necrotic core. So it's, if we just have a look at this, just by conventional imaging, we cannot make the diagnosis. Just by adding the diffusion, now we can make this diagnosis. Another application or another method based on this is that when we are talking about the brain, diffusion is not isotropic, meaning there is no one direction. If I'm talking about diffusion, the way that the molecule can move, it can move in different direction. But if we have a lot of axons and we have a lot of nerve, if the diffusion is along the axons, then it's free. It can go, if we are talking about the extra-axonal, extracellular space, diffusion is free. It's like in a macaroni, you can have a free diffusion along the axis. But if a molecule is trying to do diffusion perpendicular to the axon, then it's restricted. And the ratio, or if we are talking about what the difference is in the, or anisotropy of the diffusion, isotropy is meaning how it's parallel, if it's like a ball, in all directions it has the same magnitude, or in this case, very anisotropy. This is another very important parameter. And this is what we, on those theory, all the diffusion tensor imaging methods have been built, meaning we do acquire with at least 6 directions. There is a lot of mathematical computation. We built a tensor, we diagnosed it, we take the eigenvalues of it. That's why you learn a lot of mathematics in those courses. And then we can have a lot of information. We can have information what we call fractional anisotropy, which is just a ratio between 0 and 1. 0 meaning it is isotropic compartment, 1 is very anisotropic. We can have a mean diffusivity that we call just the mean value, like in diffusion, in the regular diffusion. And then we can relate to 2 parameters, which is the axial diffusivity, which is the more free direction of diffusion, and the radial diffusivity, which is the average of those 2 restricted diffusion. And it is known, there's a lot of trends and research to correlate those parameters to physiological. So when we are talking about mean diffusivity, we do relate to cell size. We can say if mean diffusivity is larger, then we can relate it to cell size. If we do see in specific patient a reduction or damage, increase in those values, we more related to axonal injury, like in ALS. If we do talk about changes in radial, we can relate more to myelin damage, both in demyelinating disorders or during development, what we call dysmyelinated, that the myelin doesn't form. So that's what I said in the first slide, that we do try to get information from MRI, from specific parameters, to what is going on within the tissue. If we do get information about direction, then we have this ability also to look on color-coded and to color-code it and get information about the direction. Because in T1, I'll see only hyper-intense or more intense area on fractional. But now I can see that red fibers are fibers that are crossing from right to left, like in the corpus callosum. If I have fibers that are green, like the superior longitudinal fasciculus, they are going anterior and posterior, and those red fibers for the cortical spinal tract, in this case, from top of the head to down. So, in the first study in 2000 by Peter Basser, he said, okay, I have this information of magnitude, I have this information of direction, I can make tractography. I can really build those, and this is the first, and there's a lot of advancements since there, but this is the first study that said I can make a tractography, and I can see now fibers that previously could be seen only histology. And this is other, now we can build any major fibers, the onsenate fasciculus, specific fibers that have specific function. If we are talking about the SLF, more for connection between areas relating to language function, or we are talking coronal radiata for the motor function, and we can really now build and reconstruct fibers according to the function that we are interested in. This is what we call the structural connectivity. These are the fibers that connect different brain areas, and we can learn about the myelination of them, the size of them, the anisotropy, and really have a lot of parameters that relating to the connections between brain area. But once we have those information, what do we do with this? How do we quantify? Okay, we did a beautiful study, we make a diffusion, we send to the radiologist, I said, okay, you have a map of FA, MD, DA, all parameters that I want to. What should he do with this? What are the applications? So there is a lot of method to analyze. We can just take a volume of interest and then measure those parameters, different parameters. We can do tractography, like Peter Basser showed, what we call streamline tractography, which is specific algorithm that build this. We can do probabilistic tractography, which is just a different algorithm that again try to connect areas within the brain on different assumptions and measures, and we can just make either a voxel-based comparison between groups. If we know we have a group of patients with schizophrenia and we have an age-matched control, and we want to know which brain area there is an abnormality in the structural connectivity, so we can either, if you have assumption for a specific network, we can build it. If we don't, we can do it without any assumption, either voxel-based, using TBSS or voxel-based morphometry, different algorithm. So there is a lot of method that we can do, and as I said for the fMRI, it's true for the DTI. We don't look now on specific brain area. We know that the brain is a network, and without being working correctly as a network, it won't function correctly. So now there's a lot of computational methods for taking this DTI information, do specific parcellation, choose the right area that we are interested to know the connection between them, to do this connectivity between, and then to decide which measure do we want. So we can take FA, or we can number of fibers, or we can take FA or specific lambda, or any parameter that extract from these methods and build a matrices of connectivity for each subject. Then we can take two groups, either healthy, longitudinal, or before and after therapy, just a group of patient with ALS, age-matched control, schizophrenia, compulsive disorders, whatever we want to study, and then make a specific or any statistical comparison between them and learn within these matrices where are the differences between groups. And there is a lot of effort to make these tools being available to clinical practice. But it's important to know that when you do a research for radiology, it doesn't matter if you tell him, okay, there is a huge group differences between two groups, but he wants his subject to be diagnosed. So always it's very important to take those methods and translate them to the individual diagnosis.